right, good afternoon, everyone. Welcome to our part 3 series of 5 on social determinants of veteran suicide. We welcome you today. If you would like to find any of our updates, you can go to NCGWG.org, look under minutes and group updates. You can find the meeting there. You can find the slides there as well. Today, social determinants of veteran suicide is the North Carolina Governor's Working Group, Governor's Challenge to Prevent Suicide Symposium Series. Today, we're going to focus on trauma and how that affects our mental health, emotional health, and behavioral health. Dr. Harold Kudler, Associate Consulting Professor for the Duke Department of Psychiatry and Behavioral Science, will be our moderator. Our panelists today include Martin Woodard. Martin has worked in the behavioral health field for over 30 years, initially in the U.S. Air Force, providing counseling and traveling throughout Asia, with the Inspector General's team inspecting clinics. Upon retirement, he relocated to North Carolina, where he has held key positions within Wake County Human Services, UNC School of Medicine, and the State Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, and now with the Veterans Life Center. Lisa Peterson is also with us today. She is currently the Director of Clinical Services at the nonprofit Stop Soldier Suicide. Lisa has nearly 2 decades of professional experience in the fields of health, mental health, and intellectual or developmental disability. During that time, her passion for working specifically in the trauma arena has flourished, as has her enthusiasm for educating others about trauma-informed care. Peterson is certified in rehabilitation counseling, evaluation, licensed clinical counseling, cognitive processing therapy, mind-body medicine, complex grief, integrative healthcare, and life coaching. And finally, Dr. Kevin Smythe is a clinical psychologist with nearly 20 years of experience as a provider and administrator in both private and public sectors. He is reservist in the North Carolina National Guard and has worked with both the Veterans Administration and Department of Defense. First up, Mr. Martin Woodard, we welcome you and thank you for being with us today.
Thank you. And my goal this afternoon is just to provide a brief snapshot of what we're seeing here at the Veterans Life Center. We are a residential facility located in Butner, North Carolina, where we have a total of 100 residential beds, and we have 76 which are for male, and then we have 24 that are for female. And our goal here at the Veterans Life Center is to focus on, of course, wellness, but how we focus on wellness is not just getting the veteran a job or assisting a veteran to, say, for example, address their disability. The goal of what we do is to focus on helping veterans to not only to seek and achieve a career, be it through certification, licensure, or graduation from the local community college. It's also to coordinate care for their behavioral health, for their physical health, while at the same time using life skills so that when the individuals do eventually leave and depart our campus, there's a good chance that they will be more resilient in multiple areas as a result of the services that they've received here. So this is a part of what we do. And what I wanted to talk about, if we could go to the next slide. Okay, that's what our campus looks like. And we're on state land up in Butner. And if anybody ever wants to come take a tour or visit us, by all means, feel free to drop on by. Next slide. Okay, this is what we're observing here. Once again, the majority of the residents that come into our facility are in some type of pain. And if we talk about emotional pain first, we have individuals a lot of times who are dealing with or not addressing current psychological diagnoses that they have. Or what else is going on is that if we talk about from a physical standpoint, there are chronic diseases that individuals have that really have gone untreated, such as high blood pressure, such as diabetes, and other physical ailments that are really should be addressed, but they're not being addressed. And that could be everything from not being consistent with med management, or it could be an individual that is just totally self-medicating, which I'll talk about that a little bit later. And in terms of the family discord, we see we understand that usually what happens if a veteran is homeless, they are estranged from their loved ones and even from friends. A lot of times there's a misunderstanding as to how could a veteran be in a situation where they are unaddressed, considering they may have had a very successful military career. And so what we see with the family discord a lot of times is that because of the discord, the individuals are dealing with additional stress on top of everything else that they have. And so one thing that we offer is we have an individual on our staff who does work with families, who will work with the children for, it's not always about reconciliation, because we all know sometimes that is just not possible. But what we do know is that if we're able to at least get closure, if we're able to at least get a level of understanding that the family can better understand what it is that the veteran is living with, dealing with, and what their plans are for the future, what we're finding is that it increases the chances of individuals being successful and at least some level of communication line being established and or remain open. And so the final one is, of course, substance use disorders. A good percentage, if not the majority of the individuals that we're serving are living with substance use disorders. Either they are just coming off of an active substance use disorder that has resulted in them, for example, being admitted to one of the local VAs where they are, or they were going through, they're starting to go through some level of outpatient care. And so as a result of that, what we also see, which I'll talk about in a minute, is quite a bit of self-medication that individuals will get into as a means of attempting to quiet the pain that they're going through. Ineffective, however, it works for a short period of time, which leads to danger in the long term. Next slide. What we see a lot of with a good percentage of those that we're serving is quite a bit of trauma as well as self-medication. And I put this cycle together just to demonstrate what we see a lot of is prior to enlistment, quite a few of the residents that we are working with, they had trauma even before they joined the military. I mean, if you think for a second, if recruiters were to do an ACEs score on everyone, it would be interesting how many would actually be able to become military men and women. And so as a result of that, we do know that there is quite a bit of trauma, not everyone, but there is a substantial amount of trauma that happens even before enlistment. And so then what we're seeing with our residents is that they come in and into the military and they do have a level of success. They do achieve a level of good things that have happened in terms of promotions, in terms of responsibilities and careers. But then that ends and the service is completed. And that's when issues really rear their head, because of the fact what we're talking about is the challenges that happen in adjustment. For example, there's a gentleman who he's come on the campus a few times and that I've talked to, and his name is Dr. Elbogen Duke. And he references, there's a 2015 study, he wrote a paper on it, and it was called Reducing Veteran Homelessness by Improving Money Management. And what he talked about was a lack of stable employment, in addition to difficulties budgeting and making ends meet, limited as well as compounded by limited financial knowledge, poor judgment making, as well as prudent money-making decisions, really leaded to a lot of disruption that was even deeper than homelessness. It also led to hopelessness. And so there was another study that he referenced, was talking about post 9/11 veterans, which are those that we serve, is that veterans, this was interesting, veterans who made less than $50,000, but who had proper money management skills were only 3.9% of a chance of being homeless versus someone who made over $50,000 and had bad financial habits. They were 6.6% of an increased chance of being homeless. And so I wanted to test that around the center because we do have some individuals that got out of the military and were making over $50,000. And so normally people would say, well, how could a person that gets out of the military, they got out with an honorable discharge, they went on to have a nice career and a nice life, and they were making good money, wind up homeless and wind up thinking about suicide? But the fact is, it comes down to one of the big things is money management. So it's not how less money you have. It can be even more damaging with the more money that you have. So then from there, we go to, the results can vary. Not everybody will follow this path. But what we've seen is that when individuals do complete their service, that's when the trouble, the trauma, as well as the self-medication does kick in, because, whether we like it or not, we see a lot of individuals who will self-medicate as a means to address and deal with issues they're facing. My final slide, which talks about what do we do as our response? And we call it PIT, purpose, identity, and training. One of the first things that we strive to do is for every veteran that comes in is to get them to some level of stabilization where they're actually able to stop and to think and to really focus on answering the question of, what career path would I want to pursue so that I can live a happier life? What do I need to address in terms of my behavioral health that I need to address? What are other things that are going on that I need to address? And we do that through the IVRP, the Individualized Veterans Reintegration Plan. And then we move to identity. We strive to have folks answer the question, whom do they want to become? And it may sound like, oh, that's a very basic question, but you would be surprised. There's a lot of people who appear to have everything together. That's a question that a lot of people really should take some time and answer. And so we teach resilience as well as understanding the value of gratitude. And that creates a good foundation for the residents to build upon. Finally, we have the training. And the training, of course, is not just on a career, but it's also learning more about physical and behavioral health conditions that you have and how best to manage them, how best to advocate for yourself when you're going to the doctor and you have questions about medication that you're prescribed, but you don't like the symptoms. So instead of just not taking them, you're advocating for yourself. So therefore, there can be adjustments to be made so that you don't spiral into a situation where you're rehospitalized, you are contemplating possibly harming yourself. And so we find that is just a good foundation to build upon. And then finally, in terms of the occupational and social supports, everybody needs somebody. We're firm believers that if there's one thing that everybody wants and needs, is to belong to something, to belong to someone, to have that sense of connectedness, that having that significantly decreases the chances of an individual going into the downward spiral that could lead to such things as contemplating suicide. So that's who we are, what we do, and what we build in terms of every resident that comes to our facility. And that's all that I have at this time.
Thank you so much, Mr. Woodard. We appreciate
Sure.
that. Next on the social determinants of suicide is Lisa Peterson with Stop Soldier Suicide. Welcome, Lisa. We are so glad to have you.
Thank you. Yes, thank you guys for having me. So I'm going to talk a little bit about the way that I view them as a clinician, but also the way that I train the individuals that work at Stop Soldier Suicide in our wellness center to talk to community members and clients' teams about trauma and about social determinants, but a couple other things as well. So the first slide, which I heard several folks touching on last week and this week. Martin touched on several of the points, is just kind of focusing this when you're talking about a client from a lens of trauma-informed care. So you can't really work with somebody in a trauma-informed way until you have your lens set right. And so that's one of the first things we train at Stop Soldier Suicide for our wellness coordinators who are licensed counselors and social workers, to start looking at the client and the client's environment in a little bit different of a way. So when, just as Martin said, individuals who served in the military, I would be very comfortable saying 99% of them incurred trauma before they went into the military. And it would be interesting to see how many of those went through with service if they actually took a look and saw what they had kind of incurred through their past. So I kind of talked to the folks that I train about thinking about it as like a long journey, and thinking about kind of some of the hits, stops, or things that the individuals have come through throughout their life, and taking all of that into account to find one thing in particular to start working towards someone's wellness. So we can flip slides. So one thing that we really try to preach is something called biopsychosocial care. And I'm sure that many of us are familiar with that, but really training that as a modality that we utilize when we talk to our clients and when we talk about our clients in multidisciplinary meetings and with community providers. In particular, thinking about it outside of the treatment as usual, kind of one size fits all. Let's talk about diagnoses. Let's talk about particular substance abuse or mental health issues, and really drilling down into the symptoms. And biopsychosocial really stays away from the systematic version of care. It really looks at all of the areas that are affected in an individual's life, and really trying to focus on a few root vulnerabilities. Typically, those root vulnerabilities are what are kind of traumatizing the individual the most currently. You can see that crossover effect when you have certain conversations with both team members and clients. What you'll often hear is, if you sit down at a table with a client or in a team meeting, you'll hear they're not taking their medicine, they're not showing up to appointments, I gave them the resources, they're just not calling them. And so it becomes almost like I did my part, and why can't this person do their part? And that immediately burns bridges and puts people into a place of fatigue and really trying to fight for the individual that came to you needing help. And so if you look at things through that biopsychosocial lens, it kind of gives you a fuller picture and a place to start. And I have a little visual of that in just a moment. And we can flip to the next one. So the other thing that we utilize under trauma-informed care in our training is positive psychology. And it's something that I remember hearing for the first time and thinking, oh, well, yeah, that's great. I get that. But we really undervalue positive psychology. And I kind of jokingly train my individuals at Stop Soldier Suicide in, it's you yourself first drinking the Kool-Aid and believing in it with your full heart, so that you can have that kind of drain into the individuals that you're serving and the community that supports them. Because the idea at Stop Soldier Suicide, and I know with many mental health organizations and systems, is to sell yourself out of a job. You shouldn't have to be present in that individual's life forever for them to succeed. And so if you train the system and the client in positive psychology, and you talk about the individual in ways that allow them to start viewing themselves in a different light, their capabilities, where they've come from, understanding and decreasing shame and hopelessness, it gives them a leg up. And it also gives the community providers a way in which to look at this individual in a different light. And it holds them accountable to knowing that you're only, as the kind of wellness coordinators, kind of like the advocate initially when we go in, that they're not going to allow anyone to kind of talk about the burn bridges and the mistakes or anything like that. We're going to start anew. So positive psychology allows that individual to kind of rise up from ashes when they've burnt 1,000 bridges and they haven't shown up to appointments and done all of the things that can kind of put them in a place where the community doesn't want to work for them. And we can move to the next slide. So what I like to focus on in this particular slide is we like to break down social determinants. We like to break down causal factors into like sections. We want to look at this one thing and this one thing, and we want to compartmentalize here and touch this here. And we want to say, oh, it's the TBI, or it's the anxiety or major depressive disorder. It's really hard as clinicians to step back, have the time and the ability to focus on all of the things that are encompassing this person's social determinants per se. And so a lot of the things that we see are those ACEs indicators, those pre-service trauma things that I call the coats that the person wears. Everybody comes in with many coats on. And as we kind of try and dig back into the client issues or peel back the onion, we try and kind of take off some of those coats. And we talk a little bit about trauma during service. We do see an extreme prevalence of military sexual trauma, undiagnosed traumatic brain injury, and then just some of the combat exposure that we often see around PTSD. And then poor transition is something that I hear daily. It is the rarity that we hear individuals have had a really great transition story. A lot of the discharge status has come with a poor transition, and a lot of people want to hide that from us. And so that kind of creates us even deeper or puts us even deeper in the hole to kind of help them dig out when they're ashamed to tell their story. Culture loss, the brotherhood, the kind of camaraderie is something that I've noticed, particularly in early on transition, that is the hardest, particularly when I talk with individuals who are about to transition, who are currently active duty. And that's something that they don't really know how to put a label on, and they don't know how to start the conversation or discussion around, because this is a natural transition. They knew it was coming. This is something they were supposed to be able to acclimate to. And often that's where we see some of these other factors start to bubble up in that transition and loss of culture phase, with some of the pre-service issues like abandonment and loss of brotherhood. And this is how I felt right after I was exposed to trauma. And it just brings up kind of that full force fluctuation of pre-existing trauma. And then the things we see often also include environmental issues. So what are they going back to? Do they have anything set up? Do they have a family to return to? Do they have those supports and connections? Do they feel financially ready? And also we see a great deal of legal concerns as well, not long after transitions. And so what's next is really where we kind of come in and educate both the individual we serve, active duty and veterans, and their system, whether that's a family member or we're building them a system with this trauma-informed care through a biopsychosocial breakdown via a trauma-informed and positive psychology lens. So if you'll flip to the next slide, I can show you a little bit of what we do first. So what we like to do when we start working with an individual is we have all of our model components, and we have all of our assessments and screeners and all of the fun stuff that clinicians are used to. But we like to triage case conceptualizations with this biopsychosocial diagram. And what we found that does is it allows the clinician working the case to find a triage of starting points. So as you know, anybody that works in this field, an individual comes in with a cluster of things in each one of these bubbles that are really causing them lots of concerns. But often when you kind of do this Venn diagram effect, you'll narrow it down to a few that are overarching many areas of their lives. And so that's where we really try and focus. We try and focus on the things that are really hurting them the most, that are affecting all aspects of their lives, which can give them a big boost in our confidence and ability to be able to kind of help them when they may have felt like they've turned to a lot of folks and didn't get the help or the treatment that they needed. And it also decreases some of the things that are debilitating them and keeping them from showing up to those appointments and having those honest conversations. So really getting to that root vulnerability. And what we do with these is, after the client feels super accustomed to kind of their triage plan and the clinicians working through some of these things, is we take this to their team. And we help the team really understand where the client would like to focus their care. And it just brings an extra layer of understanding through that positive psychology to help someone understand, well, they're not showing up because of X, and whatever that is. And that allows the team to fight a little bit harder, and it allows the individuals to go further through treatment or care and stick to the plan. And so I believe that might be my last slide. Let me double check. Yeah. So I put a couple of references there for the visuals for anyone that is less familiar with biopsychosocial. But I think the key is, if I had to leave everybody with one thing, it would be less on focusing on a diagnosis, less on focusing on one particular area of the individual's lives, and really digging down to seeing where the crossover areas are and starting there, because that's going to make the largest change and the most impactful change for that individual. They'll stick with you longer and you can get more work done. Thank you.
Thank you so much for that insight. It was a beautiful presentation. We look forward to talking more with you. And next, Dr. Kevin Smythe, thank you for being with us today and welcome.
Thank you very much. I appreciate it. I apologize. I'm obviously in my car. I'm currently in the DC area, so I'm not in an office where I would have a more office-friendly environment to speak today. So thank you for your patience with me. The purpose of my role, as I saw it for today, is to be more interactive, looking at some questions and sharing, my experience, having worked in multiple sectors. I feel compelled to start by sharing that last night I received a call from a colleague of mine who's currently deployed overseas. And this is somebody who is also a helper, also a behavioral health specialist. And they informed me that, sadly, there was a recent completion within the military. And of course, it's a sobering fact that so many people complete suicide, and it impacts entire families, entire units, as well as the caregivers. So it made me think a little bit about those that help veterans and those that are charged with helping them on their journey. They sometimes need help themselves, and I was thankful to be able to help a colleague last night, very timely for this presentation for today. But we've heard a little bit, agreeing with Ms. Peterson and Mr. Woodard, so much about wellness. Many of us are familiar with the 6 dimensions of wellness, and I'm reminded that those dimensions are highlighted for a reason, because coming off of a recent 12-month deployment not too long ago, I found that those areas were very significant for me, and including starting with the physical. Because so oftentimes when our veterans are in active duty or reservists and kind of going back between the civilian world and the military world, we don't often pay attention to our physical body. We look so much about mind, body, spirit, but many of our veterans are used to foregoing traditional medical care and used to having excessive amounts of caffeine. Some of them are not able to consume alcohol. Some of them somehow get it. But when we look at the amount of caffeine or nicotine or tobacco that people find themselves relying on, suddenly when you're back, you're out of that environment. It was mentioned earlier about camaraderie. Sometimes for some people, gathering around and having a cigar is the most meaningful experience they can have. And of course, now returning to different environments, we look at the physical body and how our veterans are caring for themselves, and not just involving substances or caffeine, but also diet. Basic proper nutrition, I think, are some things that need attention. But then also looking at what people return to. If we look at sort of those first 3 dimensions of, the emotional, the occupational, the physical, sometimes the fear of being able to secure employment is enough to contribute to that sense of worthlessness or hopelessness or helplessness that you often see with suicide. Of course, COVID, it was a global pandemic that many didn't see coming, but that often hampered hiring efforts for a lot of colleagues of mine, a lot of fellow veterans. And that's something that somehow has gotten personalized for a lot of veterans. It must be me, I can't find a job. When really we would know in reality, there are many organizations that either have stopped or significantly slowed hiring. Again, looking at that social connection, the camaraderie, that trusting somebody that has your back, and then all of a sudden that person has gone back to whatever state they may be from or whatever role they play. But I saw this in 15 years of working in the VA. I saw many compassionate frontline staff members who really cared and wanted to be change agents for veterans. But I also saw a struggle with providers when they would come up against maybe some person or patient or client or veteran apathy. And there would almost be a sort of a despondence, because sometimes a provider conceptualized, hey, I care more than they're caring about these treatment goals. And I would just caution everyone to say that somebody may present as apathetic, but that does not mean that they don't care, of course. And our role is to help them see that purpose, tie in that purpose of what their recovery-oriented goal is. And I think that that's just very, very important for us as helping professionals to sort of check in when we come across that. When someone is a no-show or misses an appointment, what's behind that? But again, looking at that connection of what motivates that veteran to find the new mission, because when you speak that language, when you put it in terms that are comfortable to them, it's remaining mission ready and capable for the next role that they have in their life. But I think it's very profound to look at asking those very simple, basic questions of how may I help you, and mean it. Again, I think that a lot of veterans have preconceived notions about mental health, and is it a sign of weakness to seek help or not? And we see this not only with vet centers, but with other organizations, including DoD, is how can we meet that veteran where they are? I think those are relevant questions to ask ourselves, because sometimes we don't really connect the dots as a veteran, but then also as a psychologist, is helping people connect dots. I think is so important, including spirituality. There's a level of trust among chaplains and preachers and looking at connecting that person to whatever they define as their sense of spirituality. Going back to that physical element, fitness is huge, I think, for a lot of our veterans, because that is an outlet. That could be an outlet for effective emotional discharge, and it can be an outlet for esteem building and general health and wellness. When we look at the whole health models and the integrated models that many systems, including the VA and including the private sector, are enhancing, it's less stigmatizing to have an integrative approach. I think that there's work to be done. But again, personally speaking, it's very different. I sort of joined the military later in life, but to be perfectly frank, I was motivated through my work with the Veterans Affairs to become one, to truly understand what it is that our veterans experienced. And being in for 6 years now, I mean, I think I have a grasp, but I learn every day. And I think that having that quest for knowledge and experience and cohesion, I think, is very important, because I know that when I returned, it wasn't exactly easy. You think it would be, especially as a trained mental health professional. You think, oh, I got this. But then, you come back and you say, this is it. This is what people are talking about. And I think those are important questions to ask ourselves and to bring into the therapy room. So at this point, that's all I have to offer for now, but happy to entertain questions when that time comes.
Thank you so much, Dr. Smythe. And that time is now. I will now turn the discussion over to Dr. Harold Kudler. Dr. Kudler, thank you for being with us today. It's always a pleasure to have you. And I will stop sharing so you all can see each other.
That's great. Thank you, Crystal. And thank you to all our panelists and Jeff and the organizers of this meeting. This tradition in military lecturing that you start by telling people what you're going to tell them, then you tell them, and you tell them what you told them. And my job now is to tell you what these guys told you. And so these are some notes I wrote in the course of the presentation. Starting with Martin Woodard's presentation, and thinking about, by the way, the large view of today's meeting, which is looking beyond the more narrow lens of a mental health diagnosis to think in broader terms about emotional health and well-being, to think about how we do connect with people and what is that big picture we would see if we connected the dots. I really like the way that image worked its way through a lot of the presentations. So, our speakers have emphasized that folks often don't enter the military without some history of adverse life experiences, if not frank psychological trauma. But I also want to be clear that, when DSM-3 came out with the diagnosis of PTSD for the first time, it defined psychological trauma as a stressful event beyond the range of normal human experience, which sounded pretty easy to understand until you started asking normal humans what their experience was, and you found out that, frankly, the average person has had some serious adverse effects, and many of them have had things that a lot of us would rank as psychological trauma. So I just want to, for those who might be listening and thinking, well, are people entering the military with an unusual load of trauma? Well, a certain subpopulation does, but I'm not sure it's that much bigger than the population in general. Adverse events are out there and people have to contend with them. And frankly, joining the military can be one of the best ways to become more fit to manage in life, having struggled with adversity. In Martin's comments on the importance of having basic skills in managing finances, coming out of Eric Elbogen's work, and he's well known to this group, being one of our North Carolina natives, both the UNC, Duke, and the VA. It raises the idea of social prescribing. And this idea that, can we screen veterans we serve, not just for their mental health problems and their suicide risk, although those are really important, but also for their training needs, just in coping with life in general. Parenting as well as finances, working as a couple, things like this. Can we anticipate their needs before they even go into that downhill spiral that several of you have described? A downhill spiral that I remember when these wars began in the early 2000s, people said, look, you're not going to see people immediately fall through all the cracks and get to homelessness. That's a 10-year downhill spiral. Some people get there faster, some people get there slower. But could we catch people earlier? Could we catch them, in fact, before they leave the military? Could we catch them during transition? And again, I think we now have, after 20 years of war, this new Solid Start program that's supposed to catch people before they leave the military, do some of these assessments in the more psychosocial realm, provide trainings when those would count, or at the very least, if most people leaving the military don't know what they're going to do for work, haven't figured out where they're going for school when they leave, can we get them set with a plan? May have to adjust it later, but can we get it set with a plan, and can we make that part of the handoff to VA? We're not quite there yet, but listening to Martin talk, I think that this is something that I want to emphasize and frankly catch the ideas of people in the chat about these things. In Lisa's talk, I appreciate her advocating for screening for trauma on entry into the military, and especially what she said about the biopsychosocial model. It's a mouthful, but we really need that larger lens to look at people. She suggests that looking beyond whether or not a service member or veteran has a diagnosis is really important if we're going to identify specific vulnerabilities, which may not be defined in mental health language at all, and then addressing those. I liked her talking about the value of positive psychology and of putting yourself out of a job. And I like the way she explained how do you do that? You do it by helping the veteran, and sometimes this will be for the service member too, helping them recover and exercise their own agency and their own autonomy, rather than simply letting them be the object of your care. It's a wonderful thing to be a great clinician or a great helper or caregiver, But what the real object of all this is to let them live their own lives and feel empowered to live their own life. The Veterans Life Center is, I think, entirely focused on that aim. It's not, we're going to take care of you, we're the soldiers' home, which after the American Civil War, as those soldiers aged, we created what came to be known as old soldiers' homes. But they were, and still are, some of them were known, became and were known as domiciliary. It's a lovely old-fashioned word for, here's your home, old soldier. Not a fate that most of us would look forward to. And in fact, I'll point out that what we now call domiciliaries are now dedicated to be time limited, to reskill people who have become de-skilled after years of substance use, homelessness, unemployment, living on the street. You become de-skilled and you need help. You need structure, you need social support, you need specific skills. And that's what these domiciliaries now do. Someday we'll change their name. I always have trouble spelling domiciliary, for instance. They would have changed their name. But you know, we are at least moving into the right direction. I'm hearing it in all three talks here. This idea that Lisa brings up, that we need to try to that if we focus on this or that symptom, we might miss seeing the person. That the whole idea of connecting the dots is to see the picture of the person, and then help that person move forward in their life. Which brings me to Kevin's conversation. And Kevin's been in a lot of roles in a lot of places, and I admire him being there in DC. There's a lot of action there. There's also a lot of confusion in DC, but he has the background to negotiate that. And his emphasis on wellness, you know, the VA is moving toward a wellness model. People get confused. We talk about whole health, we talk about wellness, we talk about well-being, not exactly the same thing, but at least getting at this idea that it's not enough to say you have a symptom. And if you have enough symptoms, you have a disorder. If you have a disorder, you have a diagnosis. That's not the best way to look at these things. Even if it's accurate, even if we can say, you know, there's science behind this stuff, and there is, it's not enough because it just leaves us objectifying people according to aspects of who and what they are. And we often miss that whole person when we do that. The point that, you know, we think of service members and veterans as probably being more physically fit. We just had the Marine Marathon, or perhaps we had it in Washington. Maybe it probably didn't happen, did it, Kevin? You would have seen it if it did. You know, it's kind of a COVID problem. But I always think of military people as being more fit than the average person. But on the other hand, there are a lot of things, some are stereotypes, some are real. There's a lot of smoking in the military. There's a lot of alcohol in the military. The British military, which claims to have half the rate of PTSD as every other military on earth, drinks and drinks and drinks. And I'm not sure I want to trade places with those guys. And then there's the idea that you don't need to sleep. That you didn't sleep overseas, that you miss a lot of things when you sleep, that maybe I don't need to sleep. When, as Jonathan Shea pointed out, he used to train the Marines and tried to get the Marine Corps to think about this. Sleep is the one thing that nobody else can do for you. And yeah, you could look like you're doing okay without sleep, but no, you're definitely not going to do okay if you're not sleeping. And yet, you know, we're not trained to value sleep. We don't think about our sleep. That's as much as I'm sleeping. Fine. This is something we'd be doing with the average service member veteran on the street, and maybe it would be a simple way to reach them, one of those points of contact. Kevin highlighted the importance of compassion among VA staff, and a really important point for clinicians and caregivers, including family members, that when you can be as compassionate as you want, but in some ways it can become a liability if you then get turned off when people don't seem to be mirroring that investment you're making in them. I know this feeling, and I know that it can make you feel de-skilled and incapacitated. Frankly, it reminds me a little of what you learn when you work with people who are substance users. I used to wonder, where do all the alcoholics, you know, have the secret night school that teaches them how to make their families back off by saying, if you really were compassionate, if you really cared about me, if you love me the way you keep telling me you do, I wouldn't be drinking. nothing will make people stop trying to help. And the same thing happens to clinicians. And we talk a lot about burnout. This is one element of burnout, and just one. But as clinicians and as caregivers and friends and family, we need to be careful about these things, because when we feel de-skilled, we're likely to start distancing ourselves from the people we were there to help in the first place. So one of the keys I got out of listening to what Kevin was saying was how important it is to keep faith in your patient, even if it looks like they're not getting it, they're not there, and to keep faith in yourself, and to keep finding those touch points where you can connect. And this is where one of the skills that I think was implicit in a lot of what all three of you were talking about, something often gets labeled under the heading of motivational interviewing or motivational skills, is really important. Finding a way to meet the person where they are, meet them at a point that they value. And there aren't a lot of people that don't have some point that they value that you could meet them at. It may not be taking your medicine every night. They may not value that. It may not be getting off the street. They may not even value that. But maybe there's something in their life, somebody they care about, something they care about. Maybe it's another friend on the street that you can connect with them around. You value that. What are you going to do about that? And could you help them? And what would it take for you to do to be able to help them? And now you've got the beginning of connecting and forming the kind of therapeutic relationship that then gets, I don't want to use a psychoanalytic word, that gets incorporated inside of you and becomes a part of you. And these are the real tools of living that help people move forward. This is how people grow, often through their relations with others. Finally, spirituality, building on the special role of chaplains in military culture. We have chaplains in VA. They are a terribly underutilized resource, and they connect deep into communities all around. Finally, again, I guess I'm just now repeating myself even more than I've already been doing. We tend to focus on veterans who need care, and we come in and we care for them. But often that attitude actually gets in the way of veterans learning how to take care of themselves. And that's the real goal. And it's hard to remember sometimes. But let me stop there and turn to the chats. Let's see where we are. If we have some questions, or maybe just responses in the meantime to what I've said, some give and take among our panelists, what they heard from each other. And I think you guys could all unmute yourself and we'll jump into the conversation.
For me, it was really refreshing to hear that we're in different locations, working at different aspects of the spectrum, but how we're all in sync with one another in terms of, it's like, I mean, this runs deeper than do no care, which we all take the oath for. I mean, this gets into the idea of working with veterans so that they can make the best decisions for themselves. And how we do that is we assist them to stabilize, to be resilient, to get back to having hope, get back to having fun, because the military is a fun organization, and the camaraderie that the military has, I hear a lot of times, and as someone who served 20 years in the Air Force, that is something that it's difficult to recreate on the outside. And one big reason is because there's such a high level of loyalty in the military that in the civilian world, it does exist, but it doesn't exist at the level, the breadth, or the depth that it does in the military, because in the military, it's life or death sometimes, and you can truly count on that person that's going to have your back. So that's that's just what I wanted to say, which is good to see and hear how we're in sync on this.
It really is impressive. You know, even 10 years ago, just to talk in the way we're talking today would have been considered somehow, I think, unprofessional.
Mm-hmm. Yeah, I completely agree. And I really appreciate hearing so many people talk about wellness in general to that point, and about the way that we can kind of instill that change in the people that are touching the veterans' lives. So we have to be able to build that system of support that I think we undervalue, because I think it's sometimes the hardest part to get the right people at the table at the right time, kind of doing the work together. And that kind of wellness and whole systems, holistic, all of those kind of buzzwords that you hear right now is a really wonderful idea, and it takes some time. And I think it just, if we can stay the commitment, is what I hear. Some of the things are the real struggle staying the course, but it sounds like you guys have some of the knowledge and the elements all kind of mixed in the right way, that you're infiltrating your individual communities. So that's exciting to me to know that these things are out there.
I'm looking in the questions, I'm looking in the chat, and I know we have a chat and a QA, and I think I confused people by saying go to the chat, and someone else wrote go to the QA. We'll look at both. But Rick Johnson asks a very good question. What type of training would you recommend to help veteran service officers? And, you know, veteran service officer can be confusing. We have the state veteran service officers, and I know in the VA, we tend to call the veteran service organization representatives who work in VA. Often they have offices in the VA. We call them veteran service officers too. But, you know, what type of training would you recommend to help veteran service officers when a suicidal veteran presents in the office? How do you recognize that behavior? And what's the proper way to get the veteran help? I'll throw that to the panelists. What would you recommend?
I would recommend a couple of things. If the person is already kind of in their place and they're having to kind of triage the care of the person, that's one scenario. But I would recommend a couple of trainings. Tony Pisani's Safe Side program, it's a version of a gatekeeper training, is something that I worked with my staff with right when I came on to Stop Soldier Suicide. And that can be done with anybody from bachelor's level to master's degree to licensed professional. And that's something that I found a lot of validity in, particularly around their contingency planning. And I found that that was really helpful to be the stopgap between calling emergency services and maybe that individual being able to maintain their current setting. And then I'm a big proponent of whole body medicine. So if it's kind of training your veteran services officers ahead of time, there's a program called Heart Math. And they have a resiliency program that teaches just an extremely in-depth level of trauma understanding and whole body systems, so that the providers can be better prepared to kind of view that person in a different light.
Dr. Kudler, if I could.
Yeah.
So the state has had for the last 7 years, I guess, the Veteran Support Specialist Program, which Dave Roddenberry and Dr. Moncad worked with Crystal and Colonel Falls and Brandon Wilson and a bunch of VSOs to develop, which is very specifically designed to give frontline veteran service staff some of these tools to employ. And we conduct the training annually. It's always well received and has a lengthy waiting list.
No, thank you. Thank you, Jeff. And I see also in the chat, Brian Sanguite, who is the VISN 6 Suicide Prevention Coordinator, gave a really important link to a whole set of tools and training that can also help in these issues. I want to mention, you know, the Columbia Suicide Assessment, risk assessment tool was developed. There are several different versions of it, but there's a version that's developed for use by lay people, including veteran service officers have lots of skills. But, you know, I'm not saying use it as a clinical tool in that setting, but you might say, look, let's go through this together. Let's talk about this. Let's see what we find. And then let's talk about what might work. Of course, you need to know what's available in the community. And I will say this is an easy one. VA suicide prevention coordinators are available at every VA medical center. If you just Google VA suicide prevention coordinator, a locator will pop up in your Google, and you will find the name and phone number and email address of the veteran suicide prevention coordinators at your nearest VA. You can also call the Veterans Crisis Line, 1-800, oh God, because I always think about it. Somebody give me that number, 1-800, is it
273-TALK.
Thank you.
273-TALK.
I always want to give it the wrong prefix, and I don't want to say it wrong. Yes, you can call that number 24/7. If you're even thinking, if you hang up the phone with the veteran, say, wait a minute, I'm worried about them. I don't know if I asked them the right question. I didn't, what do I do now? Call them up and ask them, the crisis line, and they'll look into this. They'll help you figure it out. They'll help you come up with a plan of action. They'll back you up, and they'll be there to speak. Thank you, Brian. It's in the chat, folks, and you shouldn't never have to have a sleepless night. Did I do the right thing? And by the way, I'm a psychiatrist. I teach psychiatrists. I've been doing this for a very long time. I don't always know I did the right thing. So I reach out to people. I share responsibility. When there's a problem and I don't really know what the answer was, I'll talk to a friend, a colleague, and I'll call the patient back and say, something, I'm still thinking about our conversation. There's nothing wrong with that. In fact, no one has ever gotten angry at me. What are you calling me back for? People usually appreciate it, and I think it helps. But maybe the other lesson I want to share is that in our community, in our culture, and I remember feeling this way when I was in college and somebody brought up this idea, I thought, do you really want to talk about suicide with people? Isn't that going to give them ideas? And the answer is, if you are listening to a person and you get the sense that they're in such pain that logically they might be feeling like life isn't worth living right now, it's okay to say, it sounds like you're really hurting. I wonder if it hurts so much that you've begun to think that life isn't worth living. Have you thought about hurting yourself? Have you made any plan to hurt yourself? Is there anything that's kind of holding you back? Anything that kind of helps you resist that? Have you reached out for help? Would you be willing to do this or that or the other thing? Often, would you call a suicide crisis? Should we call together? It's very natural to talk like that. I've never heard anybody, say, I don't want you to do that. I refuse to do that. I won't talk about that. Most people are relieved that somebody can hear them talk like this and not say, you're crazy, I don't want to have anything to do with you, or you're crazy, I don't want to deal with this anymore. It helps people feel better, and it helps them begin to come up with plans. Any other response now that I've talked so much?
One thing I just wanted to throw out there is we really just try and call it what it is. And something that we do on active duty basis that I can literally see people wince when I do it, as I say, well, let's just call it what it is. We're talking about killing ourselves. And we don't need to pretty it up, and we don't need to beat around the bush, because if we're going to do that prevention work, we really just have to make people feel uncomfortable, because suicide becomes an option that people are comfortable with because they don't have any other options, or they feel like they don't have any other options. And so something that my coordinators and through some of the training with Tony and other individuals, we've just become really, really comfortable calling it what it is. So it becomes less of an option, and that kind of like that hidden option.
We have another point in the chat that, we're quick to put the soldier in counseling, but we fail at getting family help in identifying the problem and making sure they understand what they can do to help. As a spouse, I have had to learn myself about the severe PTSD my husband suffers from. Years ago, someone sent me a copy of a Good Housekeeping article at the end of World War II that advised the housewives of America, when your man comes back from the war, if he doesn't want to talk about the war, don't bring it up. He'll talk about it when he's ready, if he's ready. And, this kind of isn't for you. And I've always wondered about that advice. It was from somebody who was famous as one of the most trusted, sort of the Dear Abby of her time. In some ways, that may sound like good advice, but frankly, it misses the point that I think Ms. Mooring is sharing with us, that this is a family affair. We just like we don't want to use the lens of, is it a diagnosis or isn't it? Is it a symptom or isn't it? Are they ill or aren't they? And if they're ill, get them to the clinic. And if they're not ill, they don't have a problem, send them out. That's not a good plan. And it's not just the individual, it's the family. And sometimes the family is the only connection you're going to see. It's the inroad. So do we have enough points of contact with family? Where do we meet and engage the family? Do we have room in our waiting rooms for the family? Do we invite family? If a family member shows up in my waiting room, I always say to the patient, I'll meet with the patient separately first, and I'll say, I noticed that your wife or your husband or your child or your mother came with you. And it always seems to me that if somebody takes the trouble to come to the VA, find a parking space and sit in my waiting room, they might want to talk to me. Would it be okay if we brought them in? And often that's the beginning of a very important conversation. And I come to see it as a signal that whether the patient exactly meant it or not, they wouldn't have let that family member come if they weren't hoping there'd be some conversation coming out of it that would be helpful. I don't know what your practice is, panelists, in working with family members.
What I'd like to say is the last person, the person who just responded and made the comment, it is spot on. What we see consistently is a lot of veterans who come in, and when we start to talk to them about their traumas and talk to them about, in particular, PTSD, what we see and hear a lot of is frustration about my spouse, my mom just doesn't understand it. And to the point where the veteran has even gone on to graphically describe some of what the individual was exposed to. And the response that we were told was one of the family member just said, well, just shut up. Don't tell me that. And so everybody is then frustrated more than when the conversation began, which it started from the idea of, why don't you just snap out of it because you're not there anymore, so just move on. And the fact is, if the family was educated about PTSD or other diagnoses that the individual is living with, it would make it much easier. So one thing we strive to do is to provide the education to the individual who really is just as frustrated as the veteran, because they just don't know. And through their lens, they're just thinking, I want my son, my daughter, my husband, my wife back. And so why can't I just get that? And it's because of the fact that they've been changed because of their life experience.
Well, Martin, how many children have grown up with parents with PTSD from the military who feel like they themselves must be inadequate because they couldn't make their parents happy because their parents seem to have these problems and somehow they weren't a good enough child to help? But how many spouses and parents have felt that way? And then they become ashamed and then they can't talk about it. Education, what's sometimes called psychoeducation, of sharing the facts. And we've got so many good tools for that. We've got them on our own website with the governor's working group. They're available through Psych Armor. They're available through, I think, a lot of the agencies here. But, are we getting them out the way we should? Are we having enough family education problems? When we have events for veterans, do we have a place where families can go and share experience with one another and also get tools and contacts? We probably can always do more like that. Going back, I was going through the link that Brian shared to the MIRAC in VISN 19, which is a suicide prevention, mental illness research, education, and clinical center in VA, which is really outstanding. It's one of the really great centers for research on this issue. You'll find all sorts of tools there, but being able to talk about it is the first step. All right, so we have another question. With the suicide rate high, are you also seeing the divorce rates are just as high for soldiers? Anybody would like to comment on that issue about divorce rates among service members and veterans?
I don't know if I would say the divorce rates are higher. We definitely see the prevalence of divorce rates. It's just a commonality of what we see. I think that's pretty much remained steady since I've been working in the field. Nothing's indicated a extreme increase or anything like that, especially around a causal factor. Something that I found interesting when I first came to Stop Soldier Suicide around this kind of topic is that I was seeing more and more individuals almost kind of like refusing to get married because they had seen so many of their buddies and military members going through marital and relationship issues, which we know is one of the highest causes for increased mental health concerns and just quality of life. And they wouldn't get married, and they would have many relationships or different types of relationship dynamics, but would not want to actually go through with marriage because some of the things they were seeing.
And something else that we've experienced is due to being more or less sheltered at home over the past year because of COVID. Divorce attorneys have been very busy, and it's not just with veterans, it's just across the country because people have decided, well, I want something different. And it's not a question if it's right or wrong, but it is the reality that due to COVID, people were sheltered in with one another and they decided they wanted to go their own way. So there has been a spike, and it's not just relegated to veterans, it's been nationwide.
One thing I can say we saw a spike in was domestic violence rates. We saw domestic violence rates go up tremendously through the first part of the pandemic in particular and through the summer of this year. I will say, based on what we've seen over the last few months, things have maybe had a downtick. States opening back up and just people feeling like they can be out of the house more, but there was a huge increase in domestic violence from our crisis line because we do have a 24/7 crisis line and just a lot more than we were used to seeing.
Yeah, I think certainly when people deploy, they're very aware of the vulnerability of their marriage. And it's a hard thing for people overseas to worry about. And then early on in our wars in Iraq and Afghanistan, at the beginning, the problem was you couldn't connect with your spouse. There were long lines to get at those computers or phones to make those connections, and the connections were unreliable. And, that was a problem. And everybody, early on, everybody was saying, oh, let's get more phones, more computers, more internet. And people did. And then the problem was you could connect too easily. And every time somebody was upset, they'd pick up the phone and call you, downrange, and you'd say, well, you think you have problems. Johnny just got expelled from school. We have a bad kid, and what the hell are you doing about it? You and your stupid war. A quote I've heard more than a few times. Why don't you get back here and fix this? This is your fault. And of course, the person downrange thinking, well, why don't I get back? And maybe I should fix this, but what can I do? And of course, like most marital arguments, these things are not what they look like on the surface. These are two people invested in a family who are feeling lost and desperate for the moment and naturally taking it out on one another. That's unfortunately what human beings do. Maybe that's why we're supposed to do that. Maybe that's why we get together to share burdens, but it can be really hard, especially when you feel helpless and you're thousands of miles away. It can be really hard. I have heard more times than anything else, I think, from people who were serving in Iraq and Afghanistan, that it was my spouse at home who had the really hard time, because I had a job that I trained for. I had these great people around me who cared about me and I cared about. I had all kinds of support, and I knew what I was doing, even as frightening as it could be, as overwhelming as it sometimes was. But my spouse at home had no rules, no support, especially in the reserve component. I've talked to lots of reserve spouses who went to family readiness groups, would drive many miles up and down mountains sometimes to get those family readiness groups and say, I'm sure as hell not going to talk about my real problems with these people because I don't really know these people. They don't know me. This might be the commanding officer's wife or husband sitting here. I'm not going to tell him my spouse has a problem, because that's not what military families really want to do. And it's not in the culture. So I think it is true that these are really hard times. Some of you who have been in this, I know Lee Feng's on this. You may remember when the Adjutant General of the North Carolina National Guard and his wife were the guest speakers at one of, I think, our very first summit, like in 2006, with the governor and others, and we kind of launched the governor's working group, the earlier version of it, and the wife was giving a speech. I think the husband was on the phone from deployment. I think that's the way it worked, and she told this story about being on the phone with him one day, and suddenly water started seeping through the ceiling, and it turned out there was a leaky pipe. And so now, instead of talking to him being in the battleground, he's trying to talk her through, well, what do you do when the water's seeping through the ceiling? And she went out and found a broomstick and knocked the holes and put a drain under, and then went upstairs and found out where the water was coming from. But it was a great story about a husband and wife separated by thousands of miles and a war, trying to solve a problem and trying to feel like a team again and actually succeeding, and how important that was, and how do we create opportunities for that to happen before, during, and after deployment? That's a real challenge. And we don't have, they didn't teach us that in medical school, I can tell you that. Maybe they teach that somewhere else. So we need to keep our eye on that ball. I want to point out somewhere also in the chat was a concern, somebody raised their experience that they tried calling the local mental health center and nobody answered the phone. And there was another follow-up on that, kind of like, well, what if, and I wasn't sure if it referred to the local center or if it was referring to the Veterans Crisis Line, 1-800-273-8255, that they wouldn't answer the phone. And I just want to make sure that people know that early on in the development of the crisis line, which originally was called the Veteran Suicide Hotline, and then the name was changed because people didn't want you to wait until you were suicidal. They wanted you to call when you were in trouble early. You shouldn't have to be suicidal to call this number. So even though it's the National Suicide Hotline, still, there was a problem with the calls rolling over. It's not like they were never answered, but they often rolled over to another line that wasn't for veterans. And then the veteran would think, well, what the hell, doesn't anybody give it to him? Why isn't this thing working? I took the trouble and I took a risk and called thinking I'd be taken care of by the VA, and now they're not there. So through a lot of hard work, and we have quadrupled the number of people who answer those calls. We have 4 call centers when we had 1. And the Veterans Crisis Line exceeds the standards for national call centers in terms of how many rings you're going to get before you get answered by a human being, and how many rollovers, if any. I mean, it is important to have a rollover system just in case for some reason that the web goes down or some crisis is going on and people are earthquake and people are calling from all over at the same time. But the fact is those calls will be answered. And I just want to say that because that old idea that no one's going to answer or it won't be somebody from the VA who's going to answer you, that's history. But I know it's a powerful disincentive to call or a good excuse not to. And it's not valid anymore and it hasn't been for years. Other points or observations?
Dr. Kudler, this is Jeff. If I could make an observation there.
Please.
And to your point, there's always technical glitches or something happens at the worst possible moment. I think that a good strategy is a defense in depth, right? We're talking about one facility. I know that there's a vet center right down the road in Greensboro, right? Have a good plan B, a plan C. We've been very lucky in North Carolina to have the support of the Cohen, Stephen A. Cohen family clinics for military families. And a significant amount of the work they do is with families. I think almost 50% The sessions that they have are with military families, and because of COVID, 95% of their services are provided via telemedicine. There's always options. There's mobile crisis, and soon here we'll have 988 coming on board, which should be another frontline resource.
Well, I want to thank and congratulate everybody in the governor's work group who is helping inform the 988 process. For those who aren't familiar with that, you know, we have 911 when you need a policeman or an ambulance or fire. Excuse me, but you know, who do you call for everything else? And 988 will be the number to call for literally everything else. Not unlike what Military One Source does now. I mean, you can call Military One Source for a full year after you leave the military, and you can call them anytime when you're in the military, and so can your spouse, so can your parents, so can your boss, if they don't know what to do about something that comes up. And Military One Source will answer the phone and provide you a full range of services, from I don't know how to change a tire, to I don't know how to balance a checkbook, to I don't know if this is a problem for which there is help. Or I don't know if this is my fault. Would you please walk me through what's going on between me and my veteran or my service member? But the 988 number will exist as a national standard, but each state will have its own system. And a number of people working with the governor's work group have been involved in a long series of long teleconferences and communications in between about how do you make sure this is a military and veteran friendly 988 here in North Carolina. This is a big challenge. A lot of people who do the same kind of work that we do and have the same job titles we have in the mental health or well-being field still don't have the military culture background, and that's key. So if others would like to get involved with that, if people are interested, this is, you know, in pre-development now, has been launched yet, but it will be soon. And it'll need refinement once it is launched. It's something good that's coming.
I was going to say that we definitely serve third parties at Stop Soldier Suicide, and work with individuals directly. That's often how we get our veterans who are scared to come and get help service as well. So we'll end up treating the family and helping the family in several different ways, from Gold Star spouses to friends of their buddies' friends, and we always try and make that connection. And we don't turn anyone away, even if we can't directly treat them. The great thing about many of our wellness coordinators is that they are are veterans themselves, spouses, children of veterans, and they have the inside knowledge, which is exactly what Dr. Kudler was speaking to be able to get you to the source that you need quicker, because they understand. Where I think a lot of times we set clients up for failure in many ways by sending them places that we don't actually know what they get when they go there. And so that's something that I felt amazing about walking into Stop Soldier Suicide in particular, because they had worked on bases or actually served themselves. So they know what barriers are going to be in place before they get there.
You know, Jeff mentioned the vet center, and I always think it's important to plug that, because even when I go to VA meetings, and I remember once going to a meeting of the North and South Carolina veterans benefits folks. These were the on-campus ones, the people who help veterans on campus manage their GI Bill, and they work on campuses all over the state, both states, and they exist in every. They may not have one for every campus. Some do circuit rides, but every campus that deals with this deals with veterans, and that's just about every campus has one. But I asked that group, how many of you know what the vet center is? And maybe out of 200 people, maybe 3 hands went up. So I never underestimate, I never want to underestimate the people, how many people know about the vet center. So after the Vietnam War, starting in the late 1970s, so you say officially, well, the Vietnam War ended at 75. So by 1978, Congress realized that a lot of Vietnam veterans weren't going to the VA. And the reason, and I started working at the VA as a resident in 1980. And my understanding of that, based on personal experience and what I've learned from others, is that in the 1970s, the VA was largely filled with World War II and Korean War veterans. And even a few World War I veterans were still around back then. And when you walked into the VA, you didn't meet people like these then young Vietnam veterans who look like kids, and I've spoken to more than a few Vietnam veterans who said when they went to the VA and looked around and felt a little confused, there were all these old men, as they put it, the World War II veterans, and they went up to the desk and said, and the person that said, "What do you want?" The Vietnam veteran said, "Oh, I don't know. Could I get a physical exam?" To which the person on the desk says, "We don't give physical exams." At which point the Vietnam veteran went home and never went back to the VA for 20 years or so when he took a job. And by the way, this particular veteran, Vietnam veteran, became the patient advocate for one of our VAs, and an extremely good one. But he partly on that experience. I remember attending a veteran service organization group. I was fishing for research subjects and went to a veteran service organization meeting to hopefully get some of these subjects. They were very nice to me, although I can imagine what I looked like to them and what I sounded like to them, thinking back to it now. But I remember the Vietnam veteran in the back of the room was allowed to be the bugler. He was the only Vietnam veteran in the group, about 80 guys, and they were all men, by the way. They let him be the bugler because I think he still had enough breath to blow the bugle. But he had no other role in the conversation, and everything was about an earlier generation. So what Congress did is they said, all right, let's find a way to make VA accessible and acceptable to Vietnam veterans where they're not going to feel stigmatized because they're not World War II veterans, and where they'll be welcomed and see pictures on the wall and meet people of their own age. And by the way, let's hire Vietnam veterans and other veterans to staff these places. The other thing they decided was this would not be medical. This would not be about being sick at all. And this goes to our theme today. This would be, the official name of the vet centers is Readjustment Counseling Services, RCS. We're not going to give medicines here, although we'll refer you back to the VA if you need them. And there are now 300 vet centers across the country. There are 100 mobile vet centers. You can't call them vans. They're mobile vet centers, each with satellite communications deployable to sites of disaster or county fairs, whatever is appropriate at the moment, and can communicate, on a hilltop in Tennessee, where there's no internet, and you can still get through. And the vet centers are a wonderful model, and as has been pointed out, they are family-centered. They have had family meetings from the beginning. They have family outings, they have picnics, they have cruises on the Delaware. They go up to the Wall in Washington and take groups up there. And although the vet center was first defined as being available to any Vietnam era veteran, which is really important because those of you who served in the military, and I never served in the military, I went right to medical school and didn't serve in the military, but I spent a lot of time with veterans, and what I've learned there, is that if you were on a nuclear submarine during Vietnam, if you were in a support position at home, if you were in a support position somewhere in Southeast Asia, if you were on a ship at sea, you may have been someone who was an interrogator who only went to Vietnam from time to time, but did something important when you were there. There are lots of reasons your DD-14 might not say you were in Vietnam, but if you served during a war, you're in that war. And so it was Vietnam era, and then it was changed to being Vietnam. You had to have served in Vietnam, but then it was with every conflict that came up, and also the realization that a lot of World War II and Korean War veterans and people who deployed in lots of humanitarian missions also needed help. So it became, if you ever deployed to a combat area, you were eligible to be in the vet center. There is no charge to be in the vet center. They will see anybody and talk to anybody about anything military. They do not turn people away. They will, if you have bad paper, they will talk to you and they will help you change that bad paper. And they will refer you anywhere within the VA or community system where you can get the help you need. And they are in, let's see if I've lost track of any. They are in Charlotte, Raleigh, Fayetteville, Asheville, Greensboro, and Jacksonville. Did I miss any folks?
Greenville.
Did I say Green? I didn't say Greenville, did I? No, and Greenville's one of the earliest ones and an outstanding one. So yeah, they're easily accessible and they're in strip malls. And you don't have to be eligible for VA. Some people aren't eligible for VA. You don't have to be enrolled in VA. You can just walk in there, and it's really, as they say, help without hassles. Very 70s, but I relate to that. Help without hassles. So I really want to put in a plug for them. Looking down here for any other questions. Yeah, 988 should be up and running in 2023. That's coming fast. Another sort of wraparound thing, and I'd be interested in what community and national organizations some of you find to be good partners. I want to mention also the Military Child Education Coalition. You know, Jeff has done a wonderful job in the working group with developing the Ask the Question campaign, which many states are undertaking, which here in North Carolina, we framed as have you or someone you love served in the military? It's a great question. I know when I first began to think about asking that question to advocate, I stole it from the Military Child Education Coalition, who had a national campaign that in every public school, they should ask every child enrolling in every public school in America at the time they register with that school, has anyone in the family served in the military? And the idea wasn't to spy on the family, but the idea was to identify military kids. And it was influenced by the fact that the average military member has a permanent change in station, which isn't that permanent, every 2 years, more or less. And so children are constantly moving with their parents. So if you start asking every child, every parent who is registering their child in school, that question, you can connect with military families all over the country and kind of, you know, keep up with them as they move around the country. And very often, the only way that, just as we're talking about spouses, the only way that you become aware of a military member or veteran or a family member in trouble is the kid is identified by the teacher in school as having a problem. They're not doing their homework, they're absent, maybe there's interpersonal violence, you know, maybe there's a suspicion of it or some other concern. And the idea isn't to spy on this family or intrude in this family, but to connect with this family. And ideally, the school principals and teachers get some background on military culture, understand some of the issues facing military families during deployments, pre and post deployment, long term. I haven't heard much about, and I'm not sure if anybody else has lately, the Military Child Education Coalition here in North Carolina. They once launched a major initiative here with Patty Shinseki leading the way. But anybody working with them these days or going to their national meetings, they still have national meetings. I recommend them. I think everybody who's on this call probably would enjoy going to those meetings. They're really amazing. And they do get wonderful updates from Pentagon folks about where things are and where things are going, and VA folks.
All right, everyone. I would like to ask one last time if we have any final thoughts from the remainder of our panelists. Dr. Smythe?
No, I think I'm good. It's a privilege to be here today. Thank you so much.
Thank you for being with us. And Ms. Peterson?
No, I don't have anything else. Thank you guys for listening and all the great topics. These were great to hear. And now I have a couple more resources that I didn't know about. So thank you.
That's what it's all about, getting those additional resources. And we appreciate you all at Stop Soldier Suicide. Truly, I think Chuck is amazing and your team is amazing. And Mr. Woodard.
Once again, thanks for having me. And I would just like to say we're approaching the holidays. Next week is Thanksgiving. And with it being that way, there will be individuals that will be in option reduction mode and will be in distress. So let's be kind, but let's also be on alert for if there's anybody that needs our help, that we can steer them in the right direction.
Everyone have your feelers out and you're looking for those red flags. And like Dr. Kudler said, don't be afraid to ask. Just ask, make it a point to ask. Are you thinking of committing suicide? Have you made a plan? So Dr. Kudler, as always, it is a pleasure to see you. I always learn so much from you. And I look forward to working with you for years to come.
Thanks, Crystal. Thank you all to the panelists and our organizers, and very happy Thanksgiving to everybody.